Dr. Johnson.
Good morning.
Good morning. Dr.
We
Johnson,
are,
good morning. Yeah. So shall
we
we
are
go
ready
to the
for you.
case?
Yes, we can. Thank you, Dr. Ronnie and the IPCI team for allowing this opportunity for a live transmission from Aster City. We have Dr. Sengottuvelu and Dr. Neil Johnson from as prominent faculty helping us with this case. Dr. Verma is also the first operator, and Sengottuvelu is also helping us out. Can we go to the case details today? This is a 62-year-old gentleman who had an effort engine and a positive treadmill in September, and he had an angio which showed a significant stenosis of LAD and LCX. An angioplasty was done in October 2021, and a 2.75 into 48 stent was put in LAD and a 2.533 stent in the LCX. So there was a recurrence of angina again, and an angio repeated outside showed an instant restenosis of the LAD and the LCX and a borderline lesion of the ramus. So we have evaluated him here. The angio was shown. The next slide.
Change the shape of it.
Can we move over? ECG was normal. The next slide, please. The parameters are generally normal. Echo showed a normal LV function. Move over. Next slide. And we are ready to show the angiographic pictures. So can we go to the live screen? Let us see the angios. And Dr. Verma, you would just talk about the angio.
Yeah. Good morning. Can you hear us, please?
Yeah.
Yeah, good morning. Dr. Verma, please go ahead.
Yeah, good morning. Dr. Verma is here with me, and happy to be here. So good morning, all of you. So we have a very interesting patient with complex multi-vessel disease. This patient has been treated in October last year, in 10 months, for the long stents for the LAD and the circumflex. So you can see the angiogram. You have a long stent from the LAD, almost close to the left main or extending a little bit in the left main, and you can see that also there is a very critical instant restenosis. In the LAD, you could see also some distal tapering in the distal left main. So, and we can also see there is a critical osteal ramus lesion. And if you look at the circ ostium, there is mild disease at the ostium. And can you show the caudal views? Yeah, you can see that the circumflex. Can you go to the other view, please, to show the ramus? Yeah. Okay. You have osteal lesion. The rest of the ramus looks all right. The circumflex, you can see the ostium is diseased, and also the stent in the circumflex, in the OM, the last OM, is again has an instant restenosis. It looks like it is quite significant from the angiogram, around 60–70% instant restenosis. And we have the right coronary artery, which is normal. So basically, this person has multiple stent failures with also native ramus disease and some native circumflex osteal disease and possibly left main disease. The right coronary artery is normal. So this is what is the angiogram. So what do you want to do in the panel? What is the plan? So our plan is today to showcase physiology. So our first plan would be to use physiology to assess the circumflex and also the ramus, and then finally the LAD. So, and of course, we will also have to use imaging because this patient has a stent failure, and we really like to use imaging as well. So first, so can you want to add something now, or do you want us to go further?
Maybe I'll go through the physiology measurements that have been made.
So we have done physiology, we have done QFR, that is a resting physiology based on angiogram alone, and we have also done invasive physiology, FFR, IFR, and now I will request Dr. Johnson to go ahead and explain the physiology, what we have seen in both the QFR and the FFR, please.
All right, thank you very much, colleagues. So as you heard, everything that has a FR at the end has been measured. What they did is they took the angiographic images, and our colleagues from METIS are calculating the QFR values. And so far we have interrogated the circumflex and the ramus, both at rest using RFR, or IFR, actually this was a volcano wire, and then also the hyperemic FFR values. We're just in the process of making the LAD measurements, but let me walk you through the physiology of the circumflex system. The circumflex system, the wire was placed in two locations. The first one was just distal to the stent in that OM branch. That vessel had a QFR of 83. The IFR value was quite negative, 95, and the FFR value itself was also negative at 95. So very mild physiology, small pressure gradients, and something that, although maybe the numbers differ among the different metrics, you would reach the same clinical decision regardless of which one you used. The wire was then pulled back to check for drift. There was no significant drift. During the pullback, there was a jump over the osteal circumflex corresponding to that eccentric lesion right at the trifurcation transition. The pressure wire was then placed out the ramus branch, and that one had 3 measurements made. So the QFR value was 83, and then the IFR number was, the QFR was 85, so a negative QFR. The FFR was 83, so also negative. Interestingly enough, in that branch, the IFR was 85, so an IFR that was just under the threshold, whereas you had negative hyperemic physiology with the FFR and QFR. During pullback, the first time we made the measurements, there was a little bit of drift, so we had to redo things, but the measurements I just gave you were successful. There was no pullback drift, but there was a jump over the proximal segment of the ramus. And so my colleagues have just finished doing an IVUS pullback through that to define the anatomy a little better at the transition, and I'll send it back to them.
Yeah. So,
Dr. Johnson, one question. So will the FFR measurement in the ramus and the circumflex will be affected by the LAD lesion, which is very significant?
Well, it's a great question. I've just received word back that the QFR of the LAD is 68. So that's something that we're just in the process of getting the pressure wire down. I must say, it's probably something that doesn't have a large effect on that. And I think the issue here is going to be much more the distal left main LAD transition anatomically. No matter how you end up treating this, I think you're going to have to consider whether or not how far you need to come back. And that may then jail the ramus branch, and you might have to make a repeat measurement after you've done the left main LAD crossover. So I think we're starting from a position where that's probably something that by itself could be left alone, but depending on how the intervention goes, might need to be addressed.
yeah, let's see.
Dr. Johnson, I have a question regarding the ramus IFR value. Both
Yes.
QFR and FFR was negative, but the
Correct.
IFR, as you mentioned, 0.85. So
Correct.
that IFR was measured after circumflex measurement. So I think that IFR value is still under some partial hyperemia and not the true IFR values.
It's a good point you bring up. You know, my colleagues here wanted to use intracoronary adenosine, so they gave a IC bolus of 200 micrograms for hyperemia. Usually that washes out fairly quickly. They were quite meticulous about flushing contrast from the catheter system. Contrast can also cause a little bit of mild hyperemia. Interestingly enough, the patient became quite hypertensive during the case and tachycardic. And so you're right, it probably wasn't measured under true baseline conditions given the hypertension and associated tachycardia from pain. They've done a successful job of using nitroglycerin and beta blockers to bring down the pressure rate product, and the patient is much more comfortable at the moment.
Dr. Johnson, would you have been better, trying to do the ramus first and then circumflex OM? Had you reverse the, sequence?
So we let the wire make the decision. Whichever branch the wire takes first is the one that we did first. Our plan was to do all 3 in sequence. I tell the fellow, whichever branch the wire goes down, that's the right one to begin with. Our goal here was, because the LED was probably going to be significant, to try to finish with the LED, keep the wire in place, and then do imaging over that to transition to the PCI part of the procedure.
Any comments from the the panelists?
We have the LED as well now live.
Let me we have some fascinating data hot off the press. This is great. So the pressure wire is down the LED. They just crossed, and I don't know if you can show these pressure tracings over here. They're just phenomenal. So this is an example of a resting, you haven't given adenosine, right?
We haven't given adenosine yet, yes.
So this is a resting PDPA of 0.48.
Are you showing this to the right?
So this is something where even when you cross with the pressure wire, you see just an enormous gradient.
Just ask them whether they're seeing this, because we are not able to see.
I just want to make sure that the camera gets transitioned over to the right monitor. We're trying to be equal to all the vendors. So we used a Volcano wire for some of them. We switched over to an Abbott wire. We're using the Boston IVUS. So we're using all the tools. And you can see the pressure tracing here, a very large gradient and a PDPA of 4.8. So that really suggests that the FFR can only be lower than that. We're just trying to move the cameras around.
We are not seeing the
We're just trying to move the cameras around to show that.
Can you?
I don't know if you can just turn it so that
now
the
we are
camera
seeing,
can show it. Now you're seeing it, fantastic, yeah.
BMW.
So, you know, this might be the kind of LED that you might not even do physiology on, given how angiographically severe it is, but I think it's always nice for demonstration, and I certainly try to do these as teaching cases, that when you have a severe lesion like that, it's an FFR 0.5. That's really what it corresponds to.
Yeah, I totally agree with Dr. Johnson. In that very, very severe region, we sometimes see resting index is lower than FFR.
Can you do a pullback?
So that's a kind of coronary physiology. So when we analyze the resting and hyperemic indices data, in regions with very tight region, usually IFR value is much lower than the hyperemic FFR.
And to your point, they've just calculated the RFR value, and it's about 0.23. So yeah, 0.23.
Can you see that on live, please? Can you see that RFR?
Can you see the RFR value in blue there is 0.23?
No, we cannot see.
Please, can you please switch to the Abbott monitor, please? Can you
Sorry,
please
we're
switch?
trying to switch over to the Abbott monitor, but to clarify, the RFR was 23. And I suspect the FFR wouldn't even be that low. So to Dr. Lee's point, a very severe resting physiology.
We cannot see it still. Can you just focus on that monitor, please?
The colleagues are working on transitioning that. I don't know, is it possible to take this and turn it right up here? Oh, now you see it. Fantastic. Great. It's up on the monitor.
So can you hear me as well?
Yeah, we can hear you.
So what we are doing is we are going to check the drift. We're going to check the drift now. We're pulling back the wire. Yeah,
we're just going to do a pullback while you're talking.
I'm just going
that
to
way
pull
we
back.
can really localize.
Can you show the
this
angiogram as well? They can see the monitor, the fluoroscopy as well, please.
And we're pulling back here. We're kind of in the mid segment, just coming into there.
Sure
oh, look at that! Look at that big jump right there. Look at that. So over that very short segment,
we are not seeing the angiogram, but we saw the. Okay.
Yeah.
Okay.
So really no significant drift. You're back to 9.9 at the guide.
What is the value? 0.99.
9.9.
Okay.
So there's no drift. It's a good measurement. And you saw, if we can show the screen up there, the one that you just had with a pullback, that was great.
Okay, I think now.
So this screen with a pullback really shows how over just a few beats, the pressure gradients completely normalize. This is extremely focal disease. And the consequence of that is that PCI can be expected to produce a very large change in FFR. Again, the FFR was going to be lower than 0.44. And that sharp transition that you're seeing, yes, I see it up there on the screen now, indicates very focal disease. So I think it matches up with our view from the angiogram as well, that the LAD was really the culprit, focal disease predominantly, and we'll do some imaging to help figure out the best treatment strategy.
So the RFR was 0.27 and FFR was 0.03, is that right?
So the RFR, the resting ratio was 0.23, and the resting PDPA was 4.8. So 23 and 48 were the resting measurements.
So what was the FFR value in the LAD? Are you going to measure FFR too?
Well, you know, I think in the interest of time and moving forward so that we can show you some stuff.
With so much of resting PDPA very low, I don't think doing an adenosine is not going to give anything additional.
It's not super crucial. It's in the interest of time, and also as my colleagues are pointing out, because it's only going to be lower than that. We're going to move ahead with the imaging, and that way when you come back to us after a few lectures, hopefully we can show you some substantial progress on that one.
And before you go, I would just like to ask your plan of management in this case.
We'll send that to the panel. What strategy would you be using at the moment?
Panel, Dr. Ramashna, Dr. Kadiresh.
Yeah. I think that you need to, you are going to plan for imaging also, I think, OCT or IVUS. And you're going to fix the LAD first, because we need to know it's a very long lesion, and there'll be, it looks like the stent is well expanded. There is a lot of neointimal proliferation is the reason. That's what superficially from the angiogram. But I think the imaging will dictate the temps.
Actually, we have done the imaging for Ramus because it's important to see that, because something very interesting in the IVUS of Ramus. So I think we'll quickly show that to you, and then the management actually makes it's a different. Can you show the IVUS please quickly, the Ramus? Can you show that? So this was done by HT IVUS, the Boston catheter. You can see the images are very clear. You can see the 3 layers of vessel wall very nicely. The distal is a distal ramus, and as we see the ramus, as we're pulling back towards the left main, you can see there's a lot of plaque near the ostium. You could see that it also correlates well with the physiology. That's a short segment with the discrete kind of a lesion.
Is that pullback from ramus?
Yes, pullback from the ramus. See, now we're seeing the circumflex. Now we're seeing the left main. What is interesting is you see the entire struts of the LAD stent floating in the left main. You can see a malaportion as well. And you see a huge malaportion you can see now. The stents are there in the left main. And now you see a left main which is having some minimal disease. So that's it. So now we have a underdeployed a malapost stent in the left main. We have a ramus which is kind of a borderline or a borderline disease, both based on physiology and imaging. We have circumflex which is not significant by both imaging. Imaging we didn't do, by physiology it is not significant, both the circumflex ostium as well as the distal circumflex. And we have a very significant, by physiology we have a very significant LAD lesion, both by angiography and by physiology is very significant LAD. So we need to treat the LAD, we need to treat the left main and possibly the ramus and not the circumflex. So do you agree with this?
Yes, I agree, but after treating the LAD, do you think we should repeat the ramus measurement to confirm the jailed ramus branch significance?
Yes. Okay, so let me tell you what we decided. We first did the OCT negative. Go forward. So what, can you show the OCT, please? So we the most important thing is now to. Okay, can you dilate it? I'll talk to them. Can you dilate the entire swing? Go up 4, 6 from the front, approximately go 10. Okay, so let me show the OCT. 6. Can you? Are you seeing the OCT?
Please go ahead.
Okay.
Yeah, we can see the OCT.
It is not moving. The screen we can see.
Before that, can you show the fluoro? Can you show the fluoro? 1 minute. Can you show the previous picture? We crossed the LAD with the wire. See, what we did was you saw the IVUS. There was a lot of malapposition in the stent from the LAD stent which is protruding into the left main. So from the ramus IVUS we could see that. So wiring was very important. Go back. Show the wiring. So we had to wire it. I know it was a bit challenging exactly to go through the left main into the very highly malaposed stent. But no. Can you show that? Yeah.
Next.
Yeah, leave that. So after we wired, you can see the balloon going from the left main into the LAD smoothly. So that confirms that we are within the stent. So once we did that, it was a very tight lesion. So we opened up the LAD with this was a NC 2.5 millimeter balloon. You just get some space to do the OCT. So once we did that, we have done the OCT. Now can you show the OCT, please? Can you show the OCT? Go up. 8, 10. 10. Is the OCT running? Negative. Okay, again, one more time. 8, 10.
Yeah, we are seeing the OCT.
Yeah. So you can just see the OCT, 10, negative.
Yeah, we can see very proliferative ISR tissue inside of the stent along the whole segment of the LAD stent. And I can see no severe calcification in the LAD target region. So I think that region will be dilated very well with the balloon angioplasty. How do you think about the expert panels?
Negative.
Panel, any comments on that?
Expert panel, let them tell their views and then we'll come back to it. Yeah.
I think there is as rightly said, there's a lot of neointermal proliferation. So we need to, we have seen that we need to reduce the volume of the tissue, whatever way. The other way is apart from the cutting balloon on very good dilation NC balloon. If we have an access to the laser, maybe it may reduce the volume of the neointermal proliferation also.
So this is after the balloon 2.5 balloon dilatation, no?
Yeah, this is after the 2.5 balloon dilatation. Okay, we'll do an
Still there are a lot
let me show you explain what we felt in the OCT. Can you show the run the OCT again. As was pointed out, this stent was a 2.75 millimeter stent, and you could see from distal. If you look at the distal vessel is quite small, and we measured the size. Show the size. So if you look at the mean diameter is 1.85. So it's a small vessel, but I think the stent, there's no edges are looking good. But there is diffuse neointimal hypoplasia. The stent seems to be expanded throughout very well. We measured, and as was pointed out, there is we can also see some balloon-induced dissections within the neointimal proliferation. So it looks like, and also importantly in the left main, can you show in the left main, go step frame by frame, you can see some malapose struts from the ostial LAD. You start and go slowly.
Can you go back? Can you go back?
Go back. That's what you're doing. Go back to the LAD. Go back to the LAD, and then go into ostial LAD, and go frame by frame into the left main.
Forward.
Frame by frame. See if you can see this. We are in the ostial LAD. You can see the struts. Now you can see that there is some the jailing of the probably the circumflex, and then you can see the ramus wire still inside the left main. So it's probably the circumflex. Keep going. So now you still see the ramus wire. This is probably the left main. Go. It's a proximal. Maybe it's a diagonal, early diagonal, or a ramus. We will not be able to tell. Go ahead. Move frame by frame. Go ahead. So now you're actually not seeing any struts very clearly, but if you can see in this frame, you can see the struts actually well. We can see that the ramus has already gone away, and this is the left main, and you have a floating stent. You have also the OCT catheter well within the stent. So probably there's a short segment of protruding stent in the left main. We saw it better with the IVUS, in fact, because of the penetration. Actually, we could see the struts better in the IVUS, but here also we can see it very well. So with this, what we decided is, since the stent is well expanded and there's neointimal hypoplasia, I think the recent classification by Waxman, he was suggesting that classify ISR as mechanical and biological. And here it looks like a biological cause. There is no mechanical cause here. And the stent was placed about 9 months back. So it's clearly a biological neointimal hypoplasia. And as was pointed out, I think we need to consider giving a local treatment with there's a diffuse lesion, so we need to consider a scoring balloon or a cutting balloon, and then probably a drug-coated balloon, a long drug-coated balloon, and maybe expand the left main stent a little bit with a bigger sized balloon. So that was our plan, and you all agree with the plan?
So this is Dr. Kadiriasan here. What is the length of the floating struts inside the left main? Is it like 1 or 2 millimeters? More than 3,
Shyam, can you measure that? See, the issue, you can measure it because clearly from the ostium or the circumflex you should measure.
Sir, this is Dr. Vijay Kumar, sir. So there's another question. See, how do you decide, see, based on OCT or your fluoroscopically, how do you decide whether to go for drug-eluting balloon or drug-eluting? Suppose you have both options. How do you take your decision?
Fantastic. So basically, as I told you, find out the cause of ISR. So whether it's a mechanical cause or a biological cause. Here, if it is a mechanical cause, it could be either due to underexpansion or it could be due to a fractured stent. So we have ruled out a mechanical cause here. There is no underexpansion, there is no stent fracture, obviously. So next is a biological cause. Biological could be either due to neoatherosclerosis or it could be due to neointimal hypoplasia. In this case, obviously, this is a short duration and we clearly see no evidence of neoatherosclerosis. So here it looks like a plain neointimal hypoplasia. And neointimal hypoplasia, the treatment of choice is to use a drug-coated balloon because putting more metal into that layer of metal is going to cause more problems later on. So you have, obviously it was a neoatherosclerosis, my decision would have been different to think of using another drug-eluting stent. But here it's a neointimal hypoplasia and I would want to avoid multiple stent layers and I want to use a cutting balloon which will probably cause a lot of lacerations and cuts which will allow into the tissue and allow the drug to penetrate. So when I use a combination of both the cutting balloon and a drug-coated balloon, probably it will be more effective, although it is quite long. That's what was my thought process.
So what balloon size are you planning? This is 2.5 you have taken to pass to allow the passage of the OCT. So what balloon are you taking now?
Yeah, actually, the plan was to measure based on OCT measurements. We wanted to use a 2.5 Wolverine distally and then maybe a 3 millimeter Wolverine proximally. That was a plan. But I think we have some limitations in the device sizes availability. So we use a 3 millimeter Wolverine distally as well as proximally. We did a cut with the 4 or 5 atmospheres distally and then 14 or 16 atmospheres proximally. And that's where we are now.
Okay.
I'd like to give one comment about the OCT finding. In the presence of very tight, very severe stenosis, sometimes the flow-mediated vessel dilation is very suboptimal. That's why in the OCT, the distal vessel looks like very small vessel. However, after balloon dilatation, that vessel is usually very dilated. So I think it would be better to choose your DCB size based on the post-balloon angioplasty OCT images.
Yeah, that's a very nice comment. But obviously, the stent is quite long, and it's a 48 millimeter stent, right? The previous stent was a 48 millimeter stent, and it's quite a long stent. So.
And Dr. Velu, did you also confirm the wire position in the Ramus branch? Because after dilatation of LAD, the Ramus branch will be jailed. So maybe confirmation of Ramus branch wire would be important.
See, the Ramus.
That's what he said. It is probably a diagonal, early diagonal. That is what he said. Yeah.
You know, it is jailed by the LAD stent. So we already have a wire in the Ramus. So we are expecting the Ramus may be jailed further, but then we need to work on that and do a kissing balloon after we finish the LAD. So let's do the OCT.
Okay.
We are doing the OCT post-cutting balloon.
Do you have any
purge.
angiographic or OCT endpoint before you do put your drug-eluting balloon? Suppose you have less than 50% diameter stenosis or an area stenosis before you decide on your DEB?
Huh? Yeah, it is. Yeah. Fine. Wait. Yeah, I know. I saw it.
Just a query, Deepak here. Just a query regarding the imaging modalities. We initially saw in the IOS that in the LED also the stent was not opposed properly. We clearly saw in the left main hardly 2 millimeter of stent which was unopposed, but then we also felt that in LED the stent was malopposed, which is not there in OCT evaluation. So why this mismatch? Is there an explanation for that?
Yes, sir. I think still there is approximately some malpositions or even OCT.
Can you show the OCT?
If you see this run, I think there is some malposition there, approximately where it just enters.
Just want to see the OCT.
This all reasonably homogeneous new market.
If we made out that whole throughout there was homogeneous
almost
proliferation.
Yeah, almost.
And we also felt that there was no space.
How do you decide between DEB and suppose based on OCT or an angiographic finding, how do you decide between DEB and this? So you have an endpoint, suppose you have a less than 50% residual diameter stenosis, that's how you choose your DEB. But suppose you have too many flaps and other things protruding into the vessel, you have to put a drug-eluting stent, right? Do you have any criteria to decide between DEB and the DES? Yeah, it is. Because you have to take a decision, right? So when do you?
Yeah, basically, Percy, when you do an OCT or any imaging in an ISR, so if it is just limited to the inside of the stent and it is a homogeneous growth, then it is very ideal for a cutting balloon and a drug-eluting stent. But if your ISR lesion is extending beyond the stent, then just using a drug-eluting balloon is still controversial. And as Vijay pointed out, if there are significant dissections, we just can't live with a balloon. We probably will have to put a stent there. And today's classifications, if it is heterogeneous, a lot of calcium, it's a neoatherosclerosis, then role of drug-eluting balloon is still controversial. But it's a homogeneous growth, limited inside the stent, then that's an
show
excellent case for cutting balloon and drug-eluting balloon usage, where you can avoid a new stent there.
Yeah, but it's expand the stent, behind the stent.
But
So,
the other
Selomani,
thing
I think that's what
is
valid thoughts. So can you see the OCT now, the post-cutting balloon? Are you? Can you see the OCT?
Yeah, we can see.
Okay.
We can see.
Can you measure the vessel size now? I think that is a good thought process to measure it after we give nitro and open it up. So I think it's a great idea to measure. And clearly the vessel size has increased now. So the vessel size.
It is much increased than pre-PCI phase.
So
and
that's again.
I can see the jailed Raymond's branch showed suboptimal flow.
Yeah.
In the angiogram, the Raymond's branch showed slow flow.
We are coming to that. So let's get the OCT fully. So are you happy with the cutting balloon dilatation? It's caused nice deep
the distal part, some areas are still
I agree.
segments.
So just measure stent diameter. So you have to make sure that stent is well expanded in all the areas.
Yeah. We measured that.
You put in a 3 millimeter stent first to get the 3 millimeter stent, then stent diameter before we do any further treatment, right? Yes.
Yeah, Vijay, we did a previous OCT. We looked at that, and
so that is normal, right?
There is no under expansion. We measured the vessel size and the stent size. There is no significant under. In fact, we saw some calcium behind the stent, but the stent is well expanded. So see, you can see some calcium here also, minor calcium in 6 o'clock position. But again, the stent was expanded well. So I don't think we need to chase that.
That's so just first take up discussion. So first thing we have to make sure that the stent is well expanded. Previous stent.
Correct. Stent is well expanded, and it's a new intimal hyperplasia. So based on this finding, I would probably take the cutting balloon again and maybe dilate distally. So because this was a 3 millimeter cutting balloon, we were very less aggressive distally because it was a smaller vessel, and we went only about 4 atmospheres. And whereas proximally, we went up to 14 atmospheres. So I think we need to cut it better distally and then go ahead with the drug-coated balloon. So what would be your choice of drug-coated balloon? The panel. What do we have here? Come, give me a cutting balloon.
Magic touch.
What?
3 size 325 is that, I think.
No, we need to cover the entire stent. So probably would look for one is about 2.75 distally. Then we need to put a 3 or 3.25 approximately, covering the entire stent because this is a diffuse neointimal hyperplasia. So I need to cover the entire stent.
Taking a 2.75 distally and the 3 proximally for the drug balloon. That is what you said.
That is what 3 or 3.25 also. Maybe they have a 3. Depending on availability. I would even go up to 3.5. Shyam, what is the vessel diameter at the proximal LAD?
I think the distal part of the LED is around 3 millimeters. So why not go with 3 millimeter distally and maybe 3.25 or 3.5 more proximally?
If Dr. Velu did further balloon dilatation at distal part of the stent, I think the 3.3 millimeter balloon would be better than 2.5.
Stent boost.
Yeah, exactly. Dr. D, you have any specific things how to decide between drug-eluting balloon and stent?
Okay, let's go.
Actually, the current guideline recommends drug-eluting stent and drug-coated balloon with the same recommendation level. So I usually decide the result of balloon dilatation. So if that is the after balloon angioplasty, if the region preparation looks perfect, I would go with the drug-coated balloon. However, after balloon dilatation, if there is recoil, huge dissection, or decreased flow, I would go with the stent.
And another thing is, if you already have multiple layers of stents, better to go for a drug-eluting balloon. And suppose you have a small vessel to treat with 2 millimeter or something, are already a branch coming from the stented segment. So these are the scenarios you just prefer more drug-eluting balloon than drug-eluting stent.
Deepak, you wanted to say something?
Yeah, Dr. Lee, you just mentioned that if the preparation is adequate enough, you would go for a drug-eluting balloon. So what is your adequacy? Do you look at the minimal luminal area? Is it somewhere around 5 or so? You would just leave it for drug-eluting balloon, or it's less than 5? Do you have a cutoff for that?
What is the drug-eluting
You all
balloon
have
have?
been discussing the same point. If you
touch.
have near through gels, you would prefer going with a stent
You have a
implantation. But here we saw that it's more of homogeneous
25, 25.
intimal hyperplasia.
Give me a
So we
2.75,
prepare it well.
25.
And how do you decide
1 minute,
based
I'll
on
talk to the panel also. Let's say what they
have a
say.
cutoff point?
Distally?
There was some publication about the ISR patterns in the OCT finding. If there is a very homogeneous neoarteriosclerotic tissue, that tissue
you have 3.5?
Mostly
you have 3, you have 2?
With TCB.
Okay. So I think we have done a nice cutting balloon dilatation again with Flextrom and with Wolverine distally. And now we are going to go ahead with drug-coated balloons. So I think the distal vessel diameter, based on the distal millimeter, I think we're going to take a 2.75. So here you could see the OCT, the average diameter is around 2.75. So maybe I can go even take a 3 millimeter distally, and proximally they don't have bigger than 3. Probably I'll have to do an entire vessel 3 millimeter. Do you all agree with or any other options? Play the picture.
It's okay.
Yeah, I agree with
two balloons.
using 3O balloon, 3O DCB for the distal would be the
you have a
choice.
Longest balloon, 3. So they have the magic touch, a sirolimus, based on nanotechnology, they have this sirolimus balloon. They give 25. Both we will need. So they have only 2 sizes, 325 and 320. So you have longer balloon? No. Okay, you can give this.
So the previous stent was 48 millimeters.
Yeah, previous stent was 48 millimeters. Okay, take 25. Okay.
So what about, there was some slow flow in the RAMs. Is it okay
show
now,
the angiogram, please. Show the previous angiogram. He's tolerating it fine. See, patient had severe angina when we did the FFR, and it was probably due to the LAD, but he's quite comfortable. Can you show the show the angiogram? You see the angiogram.
So did you do after the second cutting balloon? Did you do an OCT?
We have not done.
Okay.
I don't think it is necessary. No, the second cutting balloon they're asking. So I don't think it's necessary. I think we will go ahead and quote a drug-coated balloon, and if you want to do another OCT, we are happy to do it. And do you think you want an OCT before the drug-coated balloon?
No, I think we can go ahead.
You can go ahead, yeah.
If the previous stent was sirolimus eluting, will you go for same drug-coated balloon, or you will change the?
See, maybe most of the data is with paclitaxel eluting balloon, but I think you can discuss and tell me. But now I think the emerging data is also favoring this balloon. But only thing is we have to be sure that we have to quickly.
That was,
get the balloon
I think
inside.
the point raised was we are already the LIMS group of drug there. So do we want to go for a paclitaxel group of drug because in the balloon? That was the question that was asked.
No, that's a good question, but I think we don't have the paclitaxel eluting balloon here. And the other thing is, we don't. Maybe the panel can tell us. You think because it's not available? Do you think we should think of other options? But again, if you take another stent, also we are going to have the LIMS group of drugs. We are not going to have paclitaxel.
Yeah, that's a problem because we have limited options for drug-coated balloon.
Yes.
Yeah, I'd like to ask all the panels and the chairmen, do you think sirolimus eluting balloon would be better than paclitaxel eluting balloon? What do you expect?
No, because we don't have much data on the sirolimus eluting balloon. The data is all from the paclitaxel balloons. And only thing, the point was already the LIMS group has produced restenosis, whether we should go with another group of drug. That is what the recommendation for a drug stent or use a different drug. That was the only point which was discussed. Because we don't have other options, we should go ahead with the available sirolimus eluting stent.
Yeah, in Korea, only available option is paclitaxel coated balloon. We don't have sirolimus coated balloon.
So we don't want to keep this balloon longer in the blood, so we have quickly taken it inside. coefficient had gone up. So now it's fully inflated.
This is
10 atmospheres.
25 millimeters, 25 millimeter balloon.
Yeah, this is 25 millimeter, 2.75 because of the non-availability of the size length. So we have taken a 2.75, 25, and we have gone up to 10 atmospheres.
Dr. Velu, can you give some comment on the optimal DCB angioplasty to the all the audience about delivery time and time to inflate and total occlusion time?
Okay.
That would be important in DCB angioplasty.
I think the DCB has to be basically handled without touching the balloon and quickly taking it, having a minimal contact with the guiding and the body because you're going to lose some drugs. So take it quickly inside, always connect the inflator, everything outside, and then once you go inside, quickly start inflating. The nominal in this balloon is about 6 or 7 atmospheres. So here we have gone and look at the time. It's very important to at least have it for, we do it 2 sequences, 60 minutes first, and then deflate it. What's the time now? 1:10 negative. So we have gone more than 60 minutes, and then we will deflate for the second time for the balloon to unfold and release the remaining drug. So go up again for another 10 atmospheres, and we'll keep it for another 1 minute. So, yes.
Hari, I think we'll have to move to the talks now. Either Dr. Nils.
Anil and Sengottuvelu, shall we move to the talks? I think Dr. Johnson is giving the talk from there.
Yeah.
Yeah, we'll come back to your case after the talks.
So what we did, we wanted to take a compliant balloon so that there is no block, but we want to push the stent away. A short compliant balloon, a 6 millimeter balloon, 4 to 6, and we were able to push the struts into the left main. And in that process, there was some pinching of the ramus. Can you show that picture? So we had some pinching of the ramus, and we
bring it to the main screen. That angio, can you bring? Yeah, correct.
Okay, so after we did go back. Yeah, after this. No, you have to show the sequence, please. This is drug-coated balloon. After cutting balloon, drug-coated balloon, we did next. Go next. See this. Now you see there is a pinching of the ramus. Next, go ahead. We opened the ramus. Go ahead. Yeah, go ahead. Okay. Then we did a post-dilatation of the left main. Again, we had to place it with help of the stent boost. We were able to place it, but this is a normal looking left main. So even I am not very much worried even if I keep the balloon little bit outside the strut or the stent. So it's not diseased left main where I'll be more worried. So here we did a little bit out and then we did a post dilatation. And then you see the ramus is pinched. Now go ahead. This is the post dilatation and then with ramus is pinched. We did a kissing balloon. Next. So go ahead, next. So this was the kissing balloon. Next. So next. So after that, next. So we are here now. This is the result now. So we have, this is not where we are. So we have opened it up. Now what we want to do is, see, we are happy with the ramus. We would not do anything to the ramus. Maybe there was some pinching of the circ. I think there is probably some block shift or thrombus into the circ. So what we're going to do is we're going to do an FFR again. We saw the FFR was normal. So we will do an FFR again for this circ. And then we will do a OCT to the LED. So if you have time, we first show you the OCT because I think you will want to see the left main struts and then we will do the FFR maybe off live if there is, we can do that. Give me an OCT please. First we'll do OCT to the LED and then show them the OCT.
Yeah, I think Anil and Sengottuvelu, we have to close the session because the other session is going to start.
Okay, go ahead. So the plan, the message what I want to conclude here is, see, the first of all, physiology, this is a physiology focused session. And we did QFR, we have multivessel disease. Without physiology, we would have treated the LCX, osteum, it would have been complex PCI, treat the entire stent, circumflex stent, LED stent, circumflex osteum. But we would not have realized that there was a significant amount of malapportion in the LED stent. So that imaging also helped here. And the resting in the QFR really helped us to plan the procedure. The QFR showed that there was not significant lesions in the circ and was very highly significant in the LED. And ramus was again not significant. We have to understand the QFR is having a very high negative predictive value, which means if it is negative, it's really negative. And we did a FFR which clearly mirrored the same as QFR. So clearly QFR and FFR are not they are complementary, not that both are one or the other, but it adds value to the QFR and FFR. And based on FFR, we were able to decide that the LAD was the most significant and circumflex is not significant. So we treated the LAD. Again, OCT showed clearly a neointimal hypoplasia, diffuse instant restenosis with no underexpansion. So we took the cutting balloon with the drug-coated balloon, and we got a very nice result. We had to oppose the struts in the left main, which we did by post-irritation, and a kissing balloon. Now, I think after live, we're going to do a OCT and see how things are, and also do a FFR to the circumflex. Thank you.
Thank you so much, and because of the lack of time.
Thank you, Dr. Harikrishnan. Thank you then. I think I should thank the whole team for coming over, Dr. Masood and the technologists, and Bindu and the sisters. Thank you very much. Thank you for giving us this opportunity. Thank you, Neil Johnson. Thank you, Dr. Sengottuvelu. Thank you.